Welcome to the MCQ discussion of final MBBS examination. Today, I am going to discuss the MCQs appeared in last MBBS paper. All the MCQs are related to statistics, epidemiology, research, evidence-based medicine or demography. These MCQs appeared in the MCQ paper. I received these MCQs from the students. A study is conducted to identify whether there is an association between a new drug X and lung cancer. Out of 40 patients using the drug, 8 developed lung cancer. In the control group, out of 42 patients, 6 developed lung cancer. What is the most suitable statistical test to analyze the above data? Here, the answer is chi-squared because we are going to compare the proportion who developed lung cancer among the patients who have taken the new drug X and the control group. In order to compare the two proportions, we have to use the chi-squared test. ANOVA test is to compare two or more means. Paired t-test is to compare pre and post means. We call them as dependent means. Z-test again to compare the means, and Q-test, this is specific test. We use Q-test to detect the outliers. Let's discuss some of the theories which may be useful in the next MCQs that you face in the exam. I will refresh your knowledge regarding the statistical test. In the first column, you can see the statistical tests, and in the second column, you can see the purpose to use the specific statistical test. First test is two sample Z test or two independent sample T test or Z test. We use these T test or Z test to compare the mean of two groups, the mean blood pressure of the group A versus the mean blood pressure of group B, something like that. Paired T or Z test we use to compare the means of pre and post situation. Same group, we compare the pre-mean value against the post-mean value. For example, among 100 pregnant mothers, we can take the hemoglobin level of the first trimester and we need to compare the mean hemoglobin level in the same 100 mothers in the second trimester. One sample T or Z test, if I refresh your knowledge, we compare a group mean against a fixed value. Generally, it is a population value, but generally, in practically, we compare our sample mean against fixed value. What about one-way ANOVA? We usually call this as ANOVA. We compare two or more means. There are two or more categories. We have several means: blood pressure of group A, blood pressure of group B, average blood pressure of group C. So like that, we can compare several means using one-way ANOVA. Keep in mind, even ANOVA can be used for the situations where you use two sample t-test or z-test. Ultimately, the results will be same. The next thing that can be appeared in the exam, two-way ANOVA. Two-way ANOVA, it's almost same like one-way ANOVA, but in two-way ANOVA, we adjust for one confounding variable. For example, think that we are comparing two groups. One group consists with more females while the other group consists with more males. Even though we need to compare the height, invariably the height will be higher in the group with higher number of males. To avoid that effect, here sex is a confounding variable. To adjust this effect, we can use two-way ANOVA. Chi-square test, this is the answer for this specific question. We compare two proportions. Out of 100, this much developed disease in group A. Out of 100, this much of patients develop this disease in group B. So to compare the proportions, we use chi-square test. Pearson correlation, you can use for two continuous variables. Generally, we plot one variable in the x-axis and the other variable in y-axis. We need to determine the relationship between the fasting blood sugar level against the blood pressure. We can plot data in x and y-axis and come into conclusions. Q-test, this appeared in this MCQ. We use that to detect outliers. And one of the important thing that you need to know with regards to this statistical test, you need to know the non-parametric test. Most of the tests that we discuss up to now are parametric tests, and there's a parallel test that we call as non-parametric test. If the variable distribution is normal distribution, we use parametric test, while if the distribution is not normal, we use non-parametric test. You need to know the names of these tests because there's a possibility of appearing these tests in the exam. In two sample t-test, we compare two means, while Mann-Whitney U-test, we compare two medians. Pair t-test, we compare pre and post means, while Wilcoxon sign rank test, which is the parallel non-parametric test, where we compare the pre and post medians. One sample t-test or z-test, the non-parametric test is sign test, where we compare median against a fixed value. ANOVA or one-way ANOVA, we compare two or more means, while in Kruskal-Wallis test, we compare the medians of two or more groups. The non-parametric parallel test of Pearson correlation is Spearman correlation. In Pearson correlation, we have two continuous variables which can follow normal distribution in x and y axis. In Spearman correlation, we plot variables which may not follow the normal distribution in the x and y axis. The next one is two-way ANOVA, where we compare two or more means by adjusting for one confounding variable. The non-parametric parallel test is Friedman test. I hope that this knowledge will be important to face the next MCQs. The next MCQ appeared in surgery paper. A medical officer is going to do a research regarding cosmetic outcomes of absorbable and non-absorbable suture materials in subcuticle suture. So what is true? So this is true-false type question. The first one is blinding the assessor is not feasible. Before going into the answers, it's important to understand this design. Here, what we do is we have two groups, patients whose surgery site was sutured by absorbable suture material, other group non-absorbable suture material. We can assess the outcome in different ways. One is we can assess the outcome, whether the outcome is good or bad with absorbable suture materials, and non-absorbable suture materials, whether the outcome is good or bad. This is one way of assessing the outcome. So there may be several criteria to define whether it is good or bad, or else we can use any type of outcome measure. As the interest in this specific question is cosmetic outcome, it may be the healing duration or the size of the remaining scar, something like that. So the researcher has to define the outcome measure. However, this outcome mainly depends on several factors. Both groups should have similar size of the incision. Size of the incision matters. Size of the abdominal scar is different from the neck scar. And the same suture materials, of course, here the meaning is not same suture materials, but the same size of suture materials from one group, the absorbable, the other one non-absorbable. And the main important thing is duration from surgery to outcome assessment. The cosmetic outcome after 6 months may be different from the cosmetic outcome after 1 year. So the duration should be almost same in the two groups. Going back to the question, we can do this research in two ways. We can recruit the patients with absorbable sutures and patients with non-absorbable sutures, and we can follow up for some durations, and after 6 months or based on the researcher's requirement after 1 year, we can take the measurement. Here we don't need patients to be recruited in the same time. So the patients who are recruiting in this month, we can measure the outcome after 6 months, and the patients who are recruiting in the next month, we can assess the outcome after 6 months from the time that we recruit the patients. Or else we can do the outcome assessment by just taking the patients who has completed surgery about 6 months back or 1 year back, depending on the surgery requirement, and we can assess the outcome. If we recruit the patients by the time of starting the research, it is not feasible, it takes time. If we recruit the patients at the point of outcome assessment, that is easy, but that will create more errors because the patients may have different surgery durations, different sizes of suture, and there may be several other confounding factors affecting the outcome. So it is important to take the patient from the beginning because we can control everything. First one, blinding the assessor is not feasible. I will go for false in this answer because we can easily take a person who's an expert in cosmetic field or who's expert about the cosmetic out, and we can give the patient without mentioning the type of suture material and ask to describe the outcome of the surgical procedure. So we can easily blind the assessor. Ethical review is not mandatory. This is a study involving human participants, so ethical review or ethical acceptance is compulsory in this type of research. Implied consent is enough. Generally, we are taking patients and human participants, so it is important to have informed written consent but not the implied consent. So it is false. So the first three answers will be false, false, false. D. Retrospective study is appropriate than prospective study. As I mentioned earlier, retrospective study is feasible because we are recruiting the patients at the time of the outcome. However, there may be so many errors. As I explained earlier, prospective study, we recruit the patients just after the surgery and we control everything and we follow up. The question mentioned that what is more appropriate. Because of that, my answer for this is false because prospective is more appropriate but retrospective is more feasible. Easy. Final one, sample size should be decided before the commencement of the study. Yes, in most of the studies, unless it is very first stage or pilot testing, we need to have the sample size. So we need to calculate the sample size from the beginning. So true. Final answer is false, 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 true. This is from Gynecology and Obstetric paper regarding maternal mortality ratio. Keep in mind this is regarding the maternal mortality ratio. Before going on to the MCQs, I would like to recall some of the theory points. There are two things, maternal mortality rate and maternal mortality ratio. So this is one of the places that you might make mistakes. Maternal mortality rate is number of maternal deaths in given time period per 100,000 women of reproductive age group. Here the denominator is 100,000 women of reproductive age. Keep in mind this 100,000 is a value for Sri Lanka. In some of the other countries where they have higher maternal mortality rates, they use 10,000. If it is lower, they can go for 1 million. But in Sri Lanka, we generally use per 100,000. So this is maternal mortality rate. So maternal mortality rate we calculate, the denominator is women aged 15 to 49 years and the numerator is number of maternal deaths per year multiplied by. The important thing is this maternal mortality rate is influenced by the number of pregnancies that the women have. Because of that, people have introduced something called maternal mortality ratio. In this question, they ask about maternal mortality ratio. In maternal mortality ratio, it's number of maternal deaths in given time period per 100,000 live births during the same time period. This is the commonest measure of maternal deaths. Denominator includes the number of live births. And there are four types of maternal deaths. The first one is direct obstetric death. Direct obstetric deaths are Those resulting from obstetric complication of the pregnant state, that is pregnancy, delivery and postpartum, or interventions, omissions, incorrect treatment, or a chain of events resulting from any of the above. And keep in mind, the condition would not have occurred if the woman was not pregnant in the first place. Anything directly related to pregnancy, such as postpartum hemorrhage, like suicides due to postpartum psychosis, are named as direct obstetric deaths. Indirect obstetric deaths. Indirect obstetric deaths are those resulting from previously existing disease or from the diseases that developed during pregnancy and that were not due to direct obstetric cause but aggravated by physiological effect of pregnancy. For example, heart diseases in pregnancy. Keep in mind, maternal mortality ratio only includes direct and indirect causes in the numerator. There are two other types of maternal deaths which are not included in maternal mortality ratio, but we still call them as types of maternal deaths. Those are pregnancy related deaths. Pregnancy related deaths are the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the cause of death. This includes maternal deaths due to incidental or accidental deaths, such as elephant attack, road traffic accidents. The other type is late maternal deaths, which includes death of a woman from direct or indirect obstetric cause, but after 42 days, but less than 1 year after termination of pregnancy. These late maternal deaths and pregnancy related deaths are not included in maternal mortality ratio. Let's go back to the MCQ. Regarding maternal mortality ratio, number of maternal deaths per 100,000 live births per year. That is true. Indirect causes for deaths are included. Yes, indirect causes of deaths are included and direct causes are included, but not pregnancy related or late maternal deaths are included in maternal mortality ratio. Deaths in the first trimester included? Yes. If the cause is a direct cause or indirect cause, despite the trimester, they are included in the maternal mortality ratio. Suicides following postpartum depression are taken into calculate. This is true because suicides following postpartum depression are considered as a direct cause of maternal death. But the MCQ point here is other suicides are not included in maternal mortality ratio in Sri Lanka. If the suicide is due to something related to social problem or economical problem or something else, those are considered as pregnancy related deaths which are not included in maternal mortality ratio in Sri Lanka. But discussions are going on to include them also into the maternal mortality ratio. Death following road traffic accidents are taken into calculate. No, deaths following road traffic accidents are considered as pregnancy related deaths. They are not included in maternal mortality ratio. Okay, that is the end of the discussion. I wish you all the best for the coming final MBBS examination. Thank you very much.